let's move on with our next speaker. I've had the pleasure of meeting a couple times now, and he came out. He Skyped into our support group one day. Fantastic replies. I don't know if I shared those with you, but the comments after that meeting were phenomenal. So I'm very happy. I'm really excited about hearing his presentation, and there'll be a question and answer after he speaks as well, like we did in the last one. So let me introduce Dr. Overbaugh. Dr. Overbaugh is interventional pain management physician and anesthesiologist MD, board certified in pain management and anesthesiology, and American Board of Anesthesiologists. He's chief medical officer, solutions in pain management. He's affiliated with he's a member of the AAPM, which is American Academy of Pain Medicine, the Texas Medical Association, and he's also a member of the Spondylitis Association of America. He's a major in U.S. Army, retired, was medically retired after suffering a neck injury on active duty. Former chief of pain management at Brooke Army Medical Center, and first chief of amputee pain at Brooke Army Medical Center. That's the largest military medical center in the world. He's former chief of pain management for the New Mexico VA's health care system, currently CMO of a pain management consulting firm that provides advice to pharma on pain management, therapies, and drugs. He's also involved in direct patient care of patients suffering from pain associated with rheumatological conditions. So thank you.
Thank you. Thanks so much, Rich. Is this on? I guess, good. I have a tendency to talk loud because you got me now? Yeah, we can get the Army voice. As Rich said, I'm very, very excited to be here, and I think I had a fantastic time when we met on about a year ago, and then when we did on Skype, and kind of like the hair club for men, which I'll be joining soon. I'm not just a whatever worker. I'm a member. I have ankylosing spondylitis, and I wasn't diagnosed until after I suffered a severe neck injury on active duty, supporting our troops. And the diagnosis was made by a neurosurgeon and a gastroenterologist, of all people. Despite the fact that I had, like most of you in this room, pain for years, tired, fatigue, iritis a couple times, and just felt like I'm getting old, and I didn't, being a doctor, we all feel that we're kind of invincible, and we're not. We're human beings just like all of you, and I know that all of you go through the same suffering, and more importantly, your family members have been through a lot of the suffering with you. So I want to talk a little bit today about a comprehensive approach to pain management. A lot of us probably in the room have been the pain management doctors, and there's quite a variance out there of what you get. The newer approaches to pain management have come back to the old approaches. Pain management really is, how would you define pain? Anybody in the room have a definition for pain? Feel free. It hurts, right. Good answer. Well, it just so happened, and I have to come over here because my vision's not great, but Dr. John Bonica, he was instrumental. He was actually an Army anesthesiologist during World War II. And some of those pictures that Dr. Cush showed were actually from his patients, from recruits. Interestingly enough, Dr. Bonica was actually a professional wrestler back in the day. So he used to make money, he used to go to carnivals and wrestle people. But he took a very liking, especially to spondylitis. So he, in this country, has been labeled as the godfather of pain. The IASP is the International Association for the Society of Prevention of Pain. And pain means different things to different people. And I would like to say, being a human being, there's not one of us that hasn't experienced pain. Now, there are people with a rare genetic disorder that cannot feel physical pain. If you saw the movie, the girl with the dragon tattoo and the guy that didn't have any pain, that exists. Not for most of us, okay? But the reason why every human born has pain is Bonica was pretty insightful. I'm not sure if my laser is working, although I can't see it. Pain is, as the ISP defines it, is an unpleasant sensory and emotional experience associated with actual, so we saw the pictures that Dr. Cush was showing, or potential tissue damage, and it is described in terms of such damage. They go farther on to say that one of the most important things for all of us is pain is subjective experience. My pain is, I experience my pain differently than you experience your pain. And my colleagues, friends experience their pain differently. That's all of us. So if we try to put the round block into that square box, it's not going to work with everybody. So there's no cookbook for pain management. That's why we have to look at the patient and really have an individualized approach. Pain is associated with our perception. It's influenced by our past experiences, what we may have experienced in our past, what we experience now, and what will be experienced in our future. And then pain is dualistic, and it's either sensory or emotional experience. It's not just one or the other, it's both, okay? So when we talk about pain, and we alluded to that earlier, Dr. Cush did, the cyclic nature of pain. And a very good question by one of our patients, I think, earlier, or one of our guests. We talk about sleep, and we talk about how it affects our life. Pain is all-encompassing, right? So we have pain. And pain starts with a signal in the nervous system. So let's say I have pain in my back this morning. That leads to some neuron interception that goes to the brain. The brain says something's wrong, so then we lead to further symptoms like tense muscle, tightness, stiffness, things like that, which causes us distress. When I see pain patients that come into my clinic, if they're not having distress or they're not upset about it, I'm a little bit more concerned about that. I rarely see patients in pain come in laughing, happy, and joyous. If they do, they're probably there for another reason, and we'll talk about that later. But you know, obviously, this is a huge burden. And it's not only a burden for me as a pain patient or a physician, it's a burden for our families, tremendously. And God bless us all for having great support, right? That's why we're all here together. Okay? Pain can obviously lead to depression. We know that. We know that depression makes it harder for us to sleep. Sleep is, as Dr. Cush has said, a very restorative function. We all need to do it. And it's essential in pain management as it is in other disease states, which leads to a further guarded position. And you can kind of see where I'm going. It just feeds up and feeds up and up and up until it gets to the point where we just want to throw our hands up and say, that's enough. I quit. Well, we don't want you to do that. We want to look at pain. When I have a patient come in, and this is one thing that drove my residents nuts. I used to do a lot of teaching, and I would say to them, when you have a new patient come in with pain, you're allowed to ask one question, and you can't talk for 10 minutes. And that question is, what can I do for you today? And shut up. And they, oh, God, Dr. Overbaugh, I can't do that. The patient will give you the answer. The MRIs don't always give us the answer. X-rays don't always give us the answer, especially in spondylitis or spondyloarthropathies, is our X-rays that we commonly use lag behind the diagnosis. And that's why so many of us are diagnosed later than we should have been, or later than we could have been. Now, there's new findings in MRI and things like that, but let's be honest, when do we really get to that stage? Most of us probably, like yourselves, unlike my story, you probably went to your primary care and said, I don't feel good. And he or she said, okay, do this, that, the other thing. That didn't work. I don't know if they normally give you a direct consult to rheumatology. In my area of the country, they don't. So they end up seeing people like myself that are pain managers. And what we approach pain is everybody's unique, and there's a multidisciplinary approach to it. And we're going to talk a little bit about that, how we do an intake with you, and we have a team. It's not just me. It's nutritionists. It's, of course, a rheumatologist would be involved in our ankylosing patients. It's physical therapists. It's behavioral health psychologists. and it's also our chaplains and spiritualists. And so it's a multidisciplinary approach, and that's really what we want to go to these days, and just going to a pain clinic where I'm just going to give you pills or I'm going to give you shots and close the door. We're not achieving anything. The most important aspect of pain management is return to some sort of function or improvement in your life, right? You go there so that you can better participate and play with my nieces and nephews or my grandchildren or my children, that I can be the uncle that they want me to be. So we set goals with patients when they come in. What do you want to do? What can't you do that you used to love to do? And let's get back to some sort of modicum of enjoyment in our lives, and that's important, okay? Dr. Cush did a very good job of talking about sources of pain and spondylitis. We know, and I'm just going to show a couple here. If you look at my eye this morning, you can see that one. I've got a little bit of iritis going on this morning. It's not pink eye. You can shake my hand or just Purell yourself. But that's what, a lot of us have had that. That's what we were told. Oh, it's pink eye. It's going to go away. You get antibiotics, and it doesn't, right? And it hurts. But anterior uveitis or iritis is a pretty painful condition. Where most of us will prevent first are in two areas. One, obviously, the sacroiliac joint region. It's where your tailbone meets our hip bone. I'll show pictures of that. We call that our ilium. The second area is our lumbosacral joints, and I'm going to show you that in our exam, and they're extremely common. But the other common findings for a lot of us are what we call enthesopathies, and I think Dr. Cush explained that. Enthesitis is the part where a tendon or a muscle inserts into the bone. And many of us in this room will experience that in the morning when we get up, and oh my God, my Achilles are killing me, or my knees are killing me until I get warmed up. So that's a very common source of pain in our population of patients, and there's very targeted specific therapies for that. So when we look at pain management, we want to take, one, the whole patient. Number two, we want to treat specific symptoms. Rather than just use one agent to take care of everything, I want to be very specific in what I do and how we do it. And most importantly, the patient is the boss, to a degree. Meaning, I don't want you to hurt yourself, but I'm here to give you options and guide you. And I'll tell you if I think something's not a good idea, like bungee jumping or things like that. But I'm not going to tell you not, unless I really think it's harmful for you, okay? So sources of pain, like we mentioned, the sacroiliac joints is one of the clinical diagnoses for spondyloarthropathies in some of the New York criteria and the Bath criteria. Another major source, is the lumbosacral spine, most specifically the facet joints. And I'll talk a little bit about what the facet joints are and what we can do for that. And then the myofascial pain, meaning pain from muscles, or pain from the tendons, the enthesopathy, and that's pain at the tendons insertions. And I already alluded to pain of iritis. Okay, they're the most common things we see, and they need to be addressed specifically. Okay, this is a picture from a very famous artist, and anybody in medicine or anatomy or even art. Dr. Netter was kind of the guru of illustrating medical anatomy. It was all drawn by hand, fantastic images. And this is an image, he was well behind his time. This was done in the 60s, just showing some problems that we see in spondylitis. The typical posture that we used to see as the disease progressed because we didn't have as good therapies, kind of the humpback, or we call kyphosis. Okay, that means kind of that leaning forward posture. And then obviously this is a radiograph. This is your spine. So if I took an x-ray and I shot right through your back to your tummy, the lowest part of your spine, your sacrum, forms a joint right there. Excuse my tremors there, a little too much coffee, but that is where the sacroiliac joint is. That's the largest joint in the body. With respect to Dr. Cush, I do feel it's an important joint. It bears the most load out of any joint in the body. And when the pelvis is off, it then, that song that we all learned, the hip bone's connected to the knee bone, yada, yada, yada. When we have aberrant gait, or we walk to protect stuff, or we sit to protect stuff, we often put loads on other parts of our spine that lead to further problems. So it's almost like a kind of a house of cards or domino effect. You topple over one thing, such as the sacroiliac joint, and then the next thing happens. We get facet arthritis and this and that. So it is a very important joint in what I do for a living, and there's different therapies that we target at that. Just a little bit of explanation here, and Dr. Kush did a great job of saying that. If you look on the right, this is a picture. If I would take a slicer and I would just slice you down the middle, okay, and we're looking at your spine. In the front, okay, where your tummy would be, these are your vertebral bodies, and between everybody's vertebral bodies are discs. Discs are about 85% water. Most of us, almost all of us, if I MRI'd everybody in this hotel, and anybody that didn't have pain, 85% of us would have a bulging discs. So a lot of times what I get consults from our primary care colleagues and sometimes is the patient has back pain, he has a bulging disc, it's a disc problem. And then, well, maybe it's not a disc problem. In any MRI or X-ray, there's about 5 or 6 good reasons in people why they may be having back pain. And good physical exam and good history are essential. Good patient history is essential to help making the diagnosis. And unfortunately, or fortunately, I have made the diagnosis probably about 4 to 5 times a year of spondylitis. And it's been missed, as many of you probably have been missed before. And the most important aspect of that exam was listening to the patient. And that's why when I tell my residents and my fellows, don't just close your mouth, because we have a tendency as physicians to be paternalistic or maternalistic, and we want to tell the patient what they have, what we want to hear, so we can put them in a nice little box and say, you have this. But it's not that easy with this disease, and we all know that we live through this every day, is that we have to listen to the patient and the holistic view. And so that's what we're going to talk about. Changes in vertebral anatomy that we see in pain, and Dr. Kush alluded to. In a normal spine on the left, your back is towards the left, and your abdomen is towards the front. Along the spine, there are a ligament right here, and that's called your anterior longitudinal ligament. That's the ligament in spondylitis that starts getting calcified and starts getting inflamed. And ultimately, that calcification leads to bone formation. And it's not good bone formation, it's very weak bone formation, but that is often a site where the fusion of our spine starts as our disease progresses. As as in early spondylitis, we'll see changes back here. And these joints are called your facet joints. If our discs, through normal wear and tear, aren't serving their purpose, not being good shock absorbers, something's got to hold you up. And what holds you up is these joints, are those facet joints. It just so happens in our disease process that these facet joints also cause inflammation, and that inflammation, it causes significant pain. And not only does the pain kind of stay in the middle of the back, but it can refer pain to the buttocks, like most of us have experienced, to our thighs, usually not below the knees. So if a patient tells me they have pain to their foot, then I'm going to look at something else, perhaps a pinched nerve or things like that. But that's why it's so important to do an exam on the patient, look at exam. There's different exam maneuvers to make that diagnosis. An MRI by itself, unless it's a catastrophic injury, rarely makes the diagnosis of what we do. It can speed up the diagnosis, and I think it's important. Spondylitis Society has done that, but I think education is probably the biggest tool that we need to do. And you, being in the society, educating your physicians. I know physicians don't like to be educated. You know, Dr. Google said this, that, and anything. No, I welcome that. I want you to ask the hard questions, because when I don't find the answer to it, then I know I'm in over my head. I've got to get somebody else involved with it, okay? So spondylitis, this is the classic picture. So when I was diagnosed with ankylosing spondylitis, I thought of 2 pictures. That picture where that gentleman was hunched over like this, and this picture. And that was about the 3 minutes they spent on medical school about spondylitis back in the 90s, early 90s. Don't get it, we don't have a cure for it, and woe is you. Great, you know, that's not good. You know, and so when I got it, the first thing I did is get on the internet, and thank God we had the SAA. because they gave me a little bit of hope that there's some stuff to do. You know, physicians aren't immune to that feeling of helplessness and with disease and things like that. So sources of pain, as we said, again, the sacroiliac joints, and this is a picture of the pelvis. And the problem with MRIs and back films is they do not cut down enough to see the sacroiliac joints. So it's very common. We get an MRI of the back, like I said, shows a disc bulge, may show some large facet joints. But the MRIs if I request a lumbar MRI, you'll never get an image of the SI joints, the sacroiliac joints. And that is, you know, that's a hallmark of this disease. So you have to, plain films are good, like we talked about, but plain films will show fusion and changes well after 5 to 10 years average after the onset of symptoms. That's a long time. That's a long time not to get therapy and to get treated, right? And so unless you're looking for it, you're not gonna go order an MRI of the pelvis or sacroiliac joints. MRI technology is fantastic these days, but if we don't order the right study, we're not going to get the right answer. Okay? And then this is just another view of the bamboo spine. Again, very importantly, the back part of the spine, these joints here, facet joints, can cause a heck of a lot of pain. And we do have some very good therapies that we target at that nowadays. Pain management has come quite a long way, even from when I started. Pain management only became a specialty in 1993, believe it or not. It's a relatively young specialty. And the new approach to pain management is a multidisciplinary approach. It's not just us anesthesiologists like stick needles in people. It encompasses neurologists, physical medicine doctors, psychiatrists are involved in it now. And that's the importance of it. I don't know if I want a psychiatrist doing my neck injection, but that's a different story. Some of them are pretty good at that, though. Okay, so kyphosis, and we talked about that. And this is an MRI, and this is, I keep things simple. I like my patients to see their MRIs, and I like to explain what they mean. Because when we get the report and we read all this stuff, we think, oh my God, what did they just say? Okay, so this is an MRI. If I cut you straight down the middle, okay, and this is what's called a T1 MRI. And on T1 MRIs, water is white, okay? And on this type of MRI, it's called a stir MRI. Stir MRI, so happens to be fat is white. So in stir MRIs, they take out that fat signal, and it can actually show inflammation. So what we're looking at here is the brain, the black parts of your spinal cord, and then all of us, anybody who's had the unfortunate pleasure of getting a spinal tap, that's the fluid around the spinal canal. This is a normal looking disc. A normal looking disc has what looks like a hamburger bun in it, okay? So it looks like a hamburger bun. A black disc is a desiccated disc, means it lost its water content. In and of itself, that may or may not be your source of pain, but like we said before, as we start slicing you outwise, we see these inflammatory spots. So you all can now read MRIs. So this is the front, this is your back, this is your vertebral bodies, like nice squares like we talked about. And then we see these changes here. And these are inflammatory changes named after a radiologist named Michael Modick. So Modick changes, okay? But then as they cut out farther, we see these are the joints in the back of the spine that show inflammation. Do I get an MRI on everybody? No. If they have neurologic damage, yes, because a lot of this, again, is clinical diagnosis. But x-rays don't always show us that answer until we've become late in the disease process, okay? I had the exact same picture. This is the picture that you just saw from Dr. Cush. This is a gentleman who did not have treatment. And if we could get going up until 98, I believe, when the first biologics were released, that's what I thought. Man, you know, here I was 35 at the time, I think, and, you know, this guy's in his 40s. I mean, I'm a little older than 40 now. And that's kind of scary, you know, that's what we would see, and we would just have to deal with that. No, we don't have to deal with that anymore, okay? All right. So after laying the groundwork about what the sources of pain are, is what does interdisciplinary pain management mean? It's a multidisciplinary approach to the management of pain that must set well-defined goals. When you go to your pain management specialist, You need to set goals. And if she or he doesn't do them for you, you do them. I want to be able, at the end of my 3-month therapy, to be able to take my dog for a walk. I want to go to the playground and play with my 5-year-old and push them on the swings. Goal setting is essential, okay? Because we have to monitor progress, okay? It must be well defined. It's patient driven. No longer are the days that doctor said this, take 2 aspirin more and call me. It is patient driven, and it aims at, this is the most important thing, restorative function. So through the horrors of what we've been through in the past 2 decades, war and in World War II, there becomes good things that come out of it. And one of the good things that come out of horror and me treating amputees is different approaches to how we should do things. And the military, believe it or not, it doesn't matter what your politics are, is these young men and women are suffering. And so we found out the best way to treat them wasn't just to hand them a handful of pills like they did to my father's generation in Vietnam and say, see you later. It is, if I don't know the answer, let's get everybody together and we see the patients. And in San Antonio, where I used to work, is a center called the Center for the Intrepid. It's the amputee center for the premier amputee center in the world. Not one penny of taxpayer dollars were used to build that center. It was 660,000 people that said, I don't care about the politics of war, but I do care what it does to human beings, and they built that center. And at that center, interdisciplinary pain management is the hallmark of how these young men and women become incredible. They were incredible before. They're even more incredible after they go through that management, through the multidisciplinary management. We want to address the whole person, like I said before. You're a person, you're not a disease. You're not a pain. You're not just a hip. You're not just a SI joint. You're a human being. So we need to embrace both the physical aspect of pain and address the patient's mental well-being, psychosocial interactions, because all of our family members suffer with us and our friends do too, and then their spiritual well-being, whatever that may be. That needs to be addressed. So when we do an intake, all of those resources, all of those specialists are there. And it's important. Not one person is more important than the other. Everybody has something to say, including the patient. Okay? Pain management, and I'm sorry the colors are a little bit off. The slice, I always tell patients, kind of a slice of a pie. We don't just push one thing versus the other, like just medicines or just procedures. We want to try to use a multimodal approach so we minimize the side effects or the bad effects of a certain agent, and we maximize each of them together to act synergistically. So physical therapy, I will say, and we talked about physical modality, is actually the treatment. Pain management that allows an individual to participate in physical therapy, occupational therapy, is to be used to a means to an end. I want to do my pain management techniques or use my medicines so that Mr. Jones or Miss Jones can go on and better participate in physical therapy and occupational therapy. We've shown that with this recent conflicts throughout the world with our soldiers, and we should show it to everybody because this really is what we want to do. We want to make you better. We don't want you sliding backwards, or at least we want to prevent progression of your disease. Along with that, some parts of that include medical management, the use of medicines. Others include interventional procedures, and we're going to talk about some of them. And then behavioral health psychology. It's not just I'm sending you to the psychologist because I think you're crazy. No, that's not it at all. Patients ask me that. There's a lot of different psychological, there's a lot of literature and a lot of new techniques that they have that can be extremely helpful. And I'm going to show you some of the things that we do and that the patients will talk about that really give them relief. And then over in the blue is spiritual support. Spiritual support is very, very important in this. I can't believe how many times I've probably taken the name of my Lord in vain because of this disease or whoever you believe in. And that we need to maintain that. Okay. Pain management goals. We want to use a multimodal pharmacologic approach. We want to minimize side effects using the lowest dose possible. And when I talk about medical pain management, I'm talking about drugs, okay? Drug therapy, whether they be pain medicines, etc. We want to utilize agents that treat specific symptoms, okay? So non-steroidal agents for inflammation, different types of muscle relaxants, different types of antidepressants that can be helpful in pain management. We also want to make sure we're not duplicating problems or we're not causing drug-drug interactions. So we want to, you really should be meeting with your pain manager at a minimum of every 3 months. And in many of the pain centers that we have pharmacists that are clinical pharmacists that will also sit with our patients and meet with them and make sure that they're not suffering from side effects, et cetera, of the drugs that we use. In medical pain management, the use of drugs, the World Health Organization first came out with a step ladder. And we know in this country, we had quite a few changes. In 2004 was the year of pain. And during that time period, also in hospitals, pain became the 5th vital sign. Very, very important, right? So the prescription of opiate analgesics increased. And one of the drugs that became the #1 abused drug in this country, hydrocodone, Vicodin, was prescribed very highly. Vicodin or hydrocodone has now become a class 2 substance, meaning you can't do refills. Why did this happen? Well, I think a lot of I think there were good intentions, a lot of prescribers, and be honest with you, for opiate prescriptions in this country, 70% of them are from primary care, not necessarily from pain docs like myself. They would start patients on medications, and they give them 11 refills, and they wouldn't see them in between. Well, as you know, human nature, some things happen, and so due to the error of, or due to the problems of others, those of us who have pain suffered. And nowadays, the pendulum has swung the whole way 180 degrees over the other side. And the FDA, and I had researched with the FDA, had pretty much come out and said, we're not going to approve opiates anymore, new ones, flat out. Well, that was an irresponsible statement, so they retracted that. But because they can be helpful. Absolutely, and I don't deny that. But what we usually do with this pain medication, WHO ladder, and WHO came out for cancer relief, but we use the same principles that in cancer pain as we use in arthritis pain or other types of pain syndrome, is we want to start with non-opiate opiate adjuvants. And most of us here probably started with some sort of anti-inflammatory, whether it be Voltaren, meloxicam, Celebrex, etc. And then perhaps if pain was increasing or worsening, we may have added a muscle relaxant, Tizanidine, Baclofen, etc. And then eventually moved up to low-dose opioids. The important thing about the World Health Organization is what I often see is we start here, and starting here sometimes. We forget the ABCs, the basic stuff to treat specific problems, and we go straight to the opioids instead when we could get benefit out of it. I'm not anti-opiate at all, believe me, but that's how we look at medical management and opiate management now in the country. And we have to be advocates for patients that are on them and show that they're doing something. So when I see a patient that I have on opiates, I want to know, what can you do that you couldn't do last time you saw me? What are the side effects you're having from them? Are they working for you? Are you able to participate? Are you able to go to the concert or go to the movies without thinking about your pain? And the old 0 to 10 pain scale is just null and void. You know, how many times do you go to as a pain doctor, I don't even ask that anymore, because if I ask that, I mean, how do you quantify pain, all of us that have been, I don't know if I'm a 5 or a 6. I know when I can't get out of bed, I'm curling in pain on the floor. I know when it's not so bad, but a number, come on, that's for acute pain. That's when I smack you on the hand with a hammer. Yeah, it's a 10, okay. But most of my patients say 8, 9, okay, so it's invalid. What better is how many times, what I ask patients is, how many times a day are you thinking about that? Or how many times an hour? Or how many times a minute are you thinking, God, my back hurts, or oh man, if I could just get away with this pain. I want it to be minimal. I don't think about it most of the time, but there's some days in between. That's our goals, okay? I can't alleviate all your pain, but our goal is to minimize it to maximize function. And that's what you should be talking to your doctor. That number has become almost meaningless in our society, at least in pain management these days, okay? Move on. Different kinds of pain medications, and I'm going to have to look over here because my vision's not too good, is certainly we have the non-steroidals, which we all talked about, and then the opiates, which we'll talk about in a minute. The muscle relaxants, there's some newer muscle relaxants that are on the market. Some of the old muscle relaxants, the recent studies show they don't relax muscles at all. They just knock people out. So I guess if they knock you out, maybe you feel relaxed, but they're not doing what they're supposed to be doing, folks. So we're going to talk a little bit about that. The anti-neuropathic agents, what we talk about that are other drugs that are traditionally used in neurology for pain management that are also used for pain management in patients with pain like we have. And that would be gabapentin. A funny story about not so funny actually, gabapentin came out back in the early 90s and they thought it worked on something called GABA in the brain for seizures. It was the worst seizure drug ever created. Every single patient seized. But those patients who had diabetic neuropathy said, you know what, doc, I had 3 seizures today, but my feet feel damn good. And so it's a really good drug. And now we use it for fibromyalgia. We use it for other sources. And Lyrica is a newer, it's basically based on gabapentin, but it's a drug that it goes straight to the site without having to be metabolized. They can be very helpful in the pain that we suffer from spondylitis, okay? And then the antidepressants. Well, the traditional antidepressants, like the old school ones, like the Elavils we might have heard of, or nortriptylines, they were the most studied pain drugs there are. Do I think they're effective? I think they're effective in neuropathic pains to some point, like people who have shingles. They may help with sleep, and a lot of docs will provide them for sleep. But they do have a lot of side effects, dry mouth. People, as we get older, like myself, who have prostate problems, they can make it difficult to urinate, things like that. So we don't traditionally use them anymore. But the antidepressants that we do use are venlafaxine, which is a Effexor, and Cymbalta. And Cymbalta now has been approved for pain. It's also been approved for arthritic pain, for arthritis, believe it or not. So they're doing more and more studies with that. So we do see a lot of patients on that. And if we're concomitantly treating their depression, we know that their pain is going to get better because depression makes pain worse. And there's some newer topical agents that have hit the market. One of the ones that I would bathe in if I could is the Voltaren gel, diclofenac gel. Diclofenac's a good anti-inflammatory, but taken orally and long-term has been associated with hepatic necrosis. So it makes me a little bit nervous when I see patients chronically taking it every day. The diclofenac cream is great for those of us that have the enthesopathies, like the knee pain or sometimes the hip pain or bursitis with it. And the nice thing about it, total systemic absorption of that drug is only about 1.7%. So patients who may have history of kidney disease or liver disease, you can pretty much safely use this in reasonable doses. And I actually find it's much more helpful for me, maybe it's psychological, but it's much more helpful for me than some of the oral agents that I've been on in the past. So I do prescribe that a lot for my patients. There are compounding pharmacies now that are getting a little bit of trouble with Medicare, Medicaid because we've abused the system, but they can be helpful. Agents such as amantadine that are added to the topic, or ketamine that some of you may have heard of in the past, are now in topical agents and have a low systemic load but high efficacy for pain management. And the last thing, as Dr. Cush alluded to, is steroids. Steroids for management of the disease of spondylitis, disease that we suffer for, that we talk about, have been proven not to be as helpful as they are in rheumatoid arthritis. But steroids in small quantities, especially injected into a specific site, can be very, very helpful. Oral steroids, unfortunately, and probably why they're not effective in spondylitis, is the blood supply, the blood flow to the vertebral bodies and the disc is very poor. So significant concentrations of steroids don't often make it to that area. But if we can put it there via a needle in a lower concentration, we can often calm down the flares that you have, especially in sacroiliitis or facet disease. And that's something we'll talk about in a minute. So oral steroids for other conditions can be helpful, but they're not as effective in patients with spondylitis. And this is what we talked about. Again, I don't need to go over it. The one agent I did want to talk about here that a lot of you may not have heard of is tizanidine. Anybody on tizanidine or take tizanidine? Right. It's a pretty good medicine. Tizanidine came out in the early 2000s, and it was used for spinal cord injured patients, okay? And it works on the brain, and it works on the spinal cord, and it decreases the release of epinephrine or, adrenaline. And so it decreases the muscle spasticity. It's a cousin of a blood pressure medicine called clonidine, but it only has 1/50 of the blood pressuring effect. But it's very, very effective for the enthesopathies that we may experience, the tightness in our heels or the muscle spasm. And you can titrate the dose up. I usually start at a pretty low dose because it does make people tired a little bit. You become tolerant to it, but it's not like Flexeril where I give it to you and I hit you on the hammer and you don't wake up for a day or two. This, people are very functional. They take it at bedtime. They're not going to be hungover in the morning, and that's a key effect. The antidepressants, as we mentioned, duloxetine and venlafaxine are probably the two most common that we use in pain management. And then, obviously, the opioids ad nauseum. Some of the more common ones in this country, hydrocodone, which are in preparations of Norco or Vicodin. The morphine, oxycodone. Oxymorphone is something called Opana, which is basically oxycodone. It's a breakdown product of oxycodone. So about 5% of the population can't metabolize oxycodone. So in those who can't, we can use Opana. And then hydromorphone is allotted. And so these are some of the agents we use, but not all agents are created equal. So just because you didn't have good efficacy or good relief from one pain medicine or opiate doesn't mean another category may not be as effective for you. Okay? Interventional pain management, this is something I spent a lot of time doing. And interventional pain management, really what we do is we look at targeted therapy to targeted areas of pain. And this is one of them being our sacroiliac joint. Picture up here is of just pointing out where the sacroiliac joint is. This is what's called your ilium. Down here is where your actual hip joint is. And this is where your tailbone is. That's your sacrum. So this fine line right there, and this is with dye in it, is your sacroiliac joint. On top of that joint are ligaments, iliosacral ligaments, that run across the joint line. And they and the joint itself can cause pain. So in a lot of patients, what we will do is sacroiliac joint injections. And in those injections, we use an x-ray guidance. We use what's called fluoroscopy, so live x-ray. And we numb you up with a local anesthetic. And then we take a very fine needle, about the thickness of a hair, and we inject it into the lower portion of the joint. The sacroiliac joint is the largest joint in the body. It is a synovial joint, just like your knee or your hip. And it bears the most weight in the body. And so it does contribute to problems. When people have sacroiliitis, most of people have a protective gait or protective way in which we sit or rest. And when we do that, we often set up symptoms on the contralateral side and the upper parts of our back. So getting the injections are a means to calm down some of the inflammation to give pain relief. They're not the cure. And then I send our patients to our physical therapy colleagues that were in our clinic, and we work on stabilization of the pelvis itself, and that's very important. We will talk about complementary medicine at the end, but this is one in our realm of disease that chiropractic care can be helpful for, because a lot of people feel that kind of slips out. Manipulation can be helpful for this joint, especially in spondylitis. In time, our sacroiliac joints become fused in this disease process. And many people say, well, when it comes fused, the pain goes away. So there was about 10 years ago, no, not quite 10 years, 5 years ago, somebody asked in the question about, should we fuse them? And so they came out with this percutaneous rods where we basically, hammered a nail from here to here, or a dowel it looked like, from there to there to fuse it. And actually the results were horrendous. People did terrible because the contralateral side was worse. And so when you make a change, just like if you're building a foundation lower on in the spine, the joints above may cause problems. And that's kind of the answer is why we do not surgically fuse facet joints. The only time we really do that is in trauma, patients who have pelvic fractures, things like that. But most of the time, we won't fuse them to do that. And this is just a sacroiliac joint injection, something very common that we do. It takes a grand total of about 20 seconds to do this procedure. Patients come in, they lay on their tummy. We do give some patients a little bit of sedation if they have some anxiety. And then we just drive the needle down to the lowest part of the joint, and we inject some steroid medicine in there. And that can be, like I said, very helpful. And then we allow them to do the physical therapy. And there's some other things that you can actually buy on the internet that are pretty cheap called sacroiliac belts. I don't know if anybody's seen one. It's basically a Velcro nylon belt, and it kind of lines up where the two little dimples are on your back. And when we do exam, we examine that part of the back, and we'll often see misalignment of those hip joints. So people who have knee surgery or ankle surgery often get sacroiliitis because they're protecting. Or sometimes people have leg length discrepancies, and that can happen in spondylitis where we're protecting. So we have one leg's a little bit longer or shorter than the other. So we'll often get our podiatry colleagues involved, and we'll get shoe lifts. And they're annoying to wear when you're first wearing it. You've got to unlearn what you learned, the maladaptive way of walking, but they can help prevent this from coming back and coming back and coming back. I also see sacroiliitis a lot in women who have just given birth. As you know, the baby comes through the birth canal, it kind of stretches it. And also pregnant ladies, because the release of progesterone and estrogen makes those ligaments a little bit lax. So in our disease, very common, very important. The SI joints can be very effective, but they're not the answer. You've got to take that step farther to kind of work with a good physical therapist and have targeted sacroiliac joint physical therapy. So when I send them to the physical therapist, I say, can you please work on the SI joint? Because if not, you're just going to do the back school where they teach you to lift and stuff, and you'll say, that's great, but it didn't help my pain. So that's why we really want you to get involved with that. The second most common source of low back pain that I see in spondylitis is related to the joints that we alluded to, the facet joints, okay? Again, this being where your belly would be, this being the bumps on your back, which are called your spinous processes, the discs, and then the nerves that come down. These are the joints that form between the vertebrae to keep you straight, and these are the joints that we get a lot of inflammation in spondylitis. And some of the teaching that the SAA has done with radiologists is paying much more attention to the SI joints. It is true. When I look at MRIs, and I look at them every day, and I compare what I look at to the read, a lot of the radiologists are looking at predominantly the discs, the nerves, see if they're getting pinched, and the spinal canal. But a lot of times they don't make mention of subtle changes in the facet joints. And we're trained to rule out catastrophic things first. But if you went back and reviewed those with the patient, you'd notice that this is where we often get not only inflammation, but this is where bone spurs develop, okay? And bone spurs can develop in our disease process, just as they develop in the front here with the bamboo spine, they can also come off the facet joints. And when that occurs, the nerve's right there, and you can lead to sciatica-type symptoms. So when we look at patients, I always get frustrated when, somebody says, well, they have sciatica, they can't have a spondylitis. Well, of course they can. I mean, there's a reason for it. So it's the chicken or the egg. And in this case, our spondylitis set us up for inflammation, would set us up for bone spurs, which can pinch off that nerve, or can make their spinal canal narrow, which leads to spinal stenosis and pain. You've probably seen that on your MRI reports and things like that. There's a couple treatments for the facet joints we're going to go into, but I did want to point out this little nerve, this little guy right here. that bugger is a source of badness, but we've gotten one up on him. That nerve's called the medial branch, and what that nerve does is two things. It tells the brain, I hurt right here, my back hurts, and then it causes a reflexive spasm along the spine. And many of you, if you've had the back pain, you feel that tightness and stiffness back there. That's called your multifidus muscle or your paraspinous muscle. So when that facet joint gets angry, the reflex thing is for that muscle to contract. And that's the only thing that nerve does. So we will talk in a minute. There is a therapy that's extremely effective and very simple, in which we use a tiny needle and we use a radio waves or a microwave and we zap that sucker. Now he grows back in about 9 to 12 months. But we can get significant decrease in pain. And during that time period, which you're having good relief of pain, that's when I want to get you into physical therapy to work on core strengthening so we can rely on our abdominal muscles to kind of hold up our posture, more such so than our low back muscles, okay? And so we'll show that very quickly. This is a radiograph that shows. This is a needle. This is just the hub of the needle. And often, many times, the first time we'll go into the joint, we'll put a little bit of steroid in the joint, a little local anesthetic. And I tell patients, don't get worried if you only get relief for a short period of time. It's often, if your doctors do that to you, it's often a diagnostic procedure. Because if you get relief from it, the next step that we do, like I told you, is we take these specialized needles that we put a probe through, we anesthetize the nerve, and we lay this probe there. And that area is the area that makes a burn that destroys the nerve. Now, the burn itself isn't responsible for the 12 months relief, because most nerves, if you cut them, they'll grow a millimeter a day. So I say, Doc, why doesn't it grow back tomorrow? And the reason is with radio waves, they cause our DNA to wobble a little bit, and it forgets how to fix itself. So that's really how radiofrequency ablation works. It sounds horrendous. It's a very simple procedure. It takes about half an hour or so. And this is a practitioner. These are needles into the low back, and through them these are electrical probes. We usually give the patient a little bit of sedation. Most patients tell me it's not very uncomfortable. I've never had it done to myself. I probably will soon. And then we stimulate to make sure that we're not getting anywhere near the nerves that go to your legs, so we can see the back twitch, knowing that that's specific muscle. And we give kind of the twilight sleep for the patients. And we can, even though patients usually don't remember me talking to them, I'm asking, where do you feel this? Do you feel this in your back? Do you feel it in your leg? And that's called radiofrequency ablation, and it's a very, very good technique for the disease process from which we suffer. And that's something I do many times a week. Okay. These joints in ankylosing spondylitis or spondyloarthropathies can affect the entire spine. So as Dr. Kush was saying, normally we do see an ascension, although there's been some studies that show that some people actually, especially females, may present with ankylosing spondylitis with cervical symptoms as the first presenting factor. And usually where we see the pain is from the facet joints. And here's the facet joint in your neck. This would be your hyoid bone, your esophagus. This is the back part of your head, and this is your jawbone. And what we do is we kind of come in from the side, and we burn the little nerve as it goes to the joint. And that can offer very, very, very good relief from the pain and stiffness. So I've had patients that come in my office, and they tell me, I don't change lanes. I just get on the highway, and I know I used to do it myself, and just go straight and pray to God that nobody was next to me and get over, because I don't want to turn my head to look, or I have to kind of scoop my bottom. Thank God for the new, what's it called, Bliss or something like that have it on my Jeep so I can see if somebody's next to me, because I don't have to go good at looking over. But it allows patients better range of motion too. So it really decreases not only the pain, but decreases the spasticity that you get, because when you take out that nerve, you don't just take out the pain to the joint, you prevent it from contracting too much. Okay? And so that was we talked about two areas of a comprehensive approach. We talked about medical management. We talked about interventional management. We're going to talk a little bit about behavioral health psychology, which is a very, very important aspect of a multidisciplinary approach. And this is the practice of psychological techniques, using mind over matter, so to speak, to enhance a patient's ability to self-soothe and manage one's pain. I don't know if any of you have been through biofeedback. There's some newer biofeedback agents out there that are pretty good, and we use a lot with our soldiers, and they do fantastic at it. Of course, it's a video game generation, so they actually really like it. It's like they're playing a game, and that's good. It's some distraction. And then there's obviously cognitive behavioral therapy. Let's face it, we all, excuse my French, bitch about our pain, right? It's just a natural thing that we do, and our loved ones have to listen to that every day. So I think it's important to discuss that. It is important to get it out, and so that's why we have our behavioral health people there. It's a safe environment where you don't want to feel like you're burdening your loved ones, and we can talk about our disease and get it out. So that's part of what they do. And then there's some newer things that the behavioral health people use. There's something called alpha stimulation, and this looks absolutely crazy, believe me. But there's an enormous study that was conducted with over, I think, 30,000 troops that were injured in the recent conflicts. Some of them horrendous injuries, amputees and other things. It's called Alpha Stim. Alpha Stim this is an electrical generator, kind of look like a TENS unit if you guys have seen them before. And then there's these little clips that go on your ears, just like clip-on earrings. And then usually you wear it for about an hour or half hour, and it's set at a specific frequency and amplitude that mimics that of deep sleep, REM. And remember we talked about the restorative functions of sleep? It really does, it has been clinically proven to reduce pain significantly. And even in some of the worst cases that I've seen, patients with horrendous pain, they said, thank God for my Alpha Stim. It's expensive. I'm not sure all insurance companies pay for it, but if I was going to make a purchase, me personally, and I can't speak for you, I've used this, and I found it helped. It really did help. It really, whether it forced me to just take a time out of my day and kind of relax and control my breathing or whatnot, I found it was very, very helpful for me. So there's some good information. You can look it up on the internet, but Alpha Stim is something, I don't get paid by Alpha Stim, but it is a well-researched and clinical study-driven therapy that is available for us. Biofeedback, traditionally, a lot of you may have done that, in which we basically hook you up to monitors of your blood pressure, your heart rate, and sometimes the amount of sweat you make. And we kind of use a visual feedback in which we try to either make a game or things like that to correct our breathing, connect our mindfulness, and ultimately allows us to release endorphins and enkephalins. And those are the natural painkillers that we have in our body. Unleashing them is very effective. It causes something called the gate theory. And what that does is prevent pain from reaching the brain. And so biofeedback is very effective. A newer type of biofeedback these days are called SCANAR, SCANAR. And if you go to a multidisciplinary pain clinic, ask if they do have SCANAR. SCANAR it incorporates biofeedback with some TENS type things, and it's pretty interesting therapy that we've used in the Department of Defense, and it's very effective for some people. Some people do great with it, some people don't, but it is another option that I wanted to make you guys aware of that's out there for you. Okay? This is something that we all talk about, and I'll be honest with you, I'm probably the worst person about doing it, but it is the most important. And what we do here with pain management is we want to get your pain better controlled so you can better participate in occupational and physical therapy. Why do we fuse like this? Has anybody garnered to ask in ankylosing spondylitis? It's not the disease itself that does that. It's the fact that that's our natural position of pain relief, right? And if you ever go to, I don't know what the supermarkets up here, down in San Antonio, they're H-E-B, Piggly Wiggly, whatever, and you watch people walking like this on the shopping cart. We actually call that the shopping cart sign. It's actually a recognized medical finding. And what that often does is help open up the spine. It opens up those facet joints and it relieves pain. You walk like that. The problem in spondylitis, if we maintain that position all the time, we're going to fuse in the position that we maintained most, and that's where our physical therapists get involved. We want to look at extension-based therapy, okay? So there are, when you meet with your physical therapists go through a tremendous amount of training now, and they're very familiar with this disease, but we really want to look at extension-based so we don't cause the tightness of these muscles that lead to us in the forward posture. The motto, I guess, on all of our bracelets says stand tall, and there's a reason for that. We stand tall. If we do eventually fuse, we're going to fuse in a straight posture rather than the contracture type posture. So stretching, and especially of the hip joints, of the multifidus muscles in the back are essential in our disease. The sooner we get involved and the more we get involved, it's important to do that. The other things that we're going to talk about, physical modalities, TENS unit and something called interferential stimulation, ultrasound therapy. There's something called cold laser therapy. If anybody's experienced that, it's actually pretty interesting. We'll go over that a little bit. Desensitization is where we gradually introduce a kind of noxious stimuli until we become more aware of it. It's almost like people when you go through, let's say I have a phobia of spiders, and they go through the desensitization thing where I look at a little spider and then eventually work my way up to a tarantula and yeah, kind of like that. But instead it's for pain. And then I wholeheartedly agree with Dr. Kush that aquatic therapy is the best therapy that we find. And if you can look around, look for those places that have warm water therapy, okay? A lot of them have pools that are heated to close to body temperature, 90, 95 degrees. And it just takes that initial shock when you get in the pool that you naturally want to tense up. It kind of relieves it, and it can be very, very helpful. So this is a TENS unit. TENS units work for a couple different reasons. Obviously, and nowadays we use something called interferential, which is a little bit more involved. TENS units not only kind of give you that deep massage feel, what they actually do through clinical studies is they cause the release of endorphins, like we talked about, and enkephalins in the spinal canal, in the spinal fluid, which lead to binding of anti-pain receptors and can be very helpful for the pain that we experience. So it's not just the physical kind of the muscle type tingling or kind of the massage type part of it that works. It's actually that it causes the release of chemicals. It also antagonizes something called NMDA, and NMDA is the glutamate receptor, and glutamate, which is in what's the blue sweetener? NutraSweet, aspartame. Another thing we'll talk about, diet. That's a pain increasing agent that we find in the spinal fluid. And besides of trying to avoid those things, that is what TENS causes to prevent. Okay. Laser therapy is pretty interesting. I wasn't too aware of that until I got involved with some of my colleagues from the physical medicine and rehab departments. And laser therapy can do a couple things. It helps with the myofascial component of your pain, and it helps desensitize the fine nerve endings that go to some of the joints and some of the muscles themselves. So that's, some people have very good response to it, some people don't. In pain management, a lot of what we do, and let's be serious, is trial and error. My philosophy is to guide you away from things that are going to hurt you, like I said, do no harm. If it helps, who am I to say? Because pain is personalized, who am I to say not that it doesn't work? And that's truly what I believe. Is it going to slow the progression of our ankylosing spondylitis? I don't know. Okay, but is it going to increase our functionality, decrease our pain? Maybe. So then I think it's fine to do. And people get relief from this. This is aquatic therapy. I actually did this myself after a knee surgery, and I thought, no way, you know, it's not going to be that grueling. I'll tell you, it was a fantastic workout, and you just don't have the pounding or the jarring that you would have in running and things like that. If you've ever kind of walked briskly or tried to jog in a pool, you actually get a pretty good workout. You know, if you have a circular pool, you don't want to keep going the same direction because you're just going to be going with the current. So change directions, but just movement in the pool is definitely helpful. It helps with the enthesitis. It helps with the joint pain. It helps prevent osteoporosis. Weight-bearing exercise is very important, not just for women, as we said, but for men too, especially in our disease process. We make more bone, but the bone we make is not good. And so we are subject to osteopenia and osteoporosis. So aquatic therapy, I really do, if you can get in the pool, if you can get into like the heated programs or physical therapy in the pool, that's one thing I really do advocate. And then lastly, we're going to talk about alternative and complementary pain management. And this is a kind of exciting thing. At the clinic that I left at the Army, we actually had 2 chiropractors on staff. We had 2 acupuncturists. We did have lunchtime yoga. We didn't have a Tai Chi specialist, but we said we would actually love to have somebody that does that. And then we did have some therapists that help with meditation and then mindfulness. And they can all be very helpful in the management of disease. Don't underestimate what we were given in our bodies. I mean, we've gotten a bad disease, but we do have means to use our own bodies and what we're wired with to make us better. So acupuncture has clinically been proven. I know there's some controversy of that. The caveman, or whatever that is, woolly mammoth, he liked it. I've actually had it done to myself, and there have been clinical trials that say it helps. Now, again, it does not slow the progress of disease. Remember, we're talking about pain management. It has been clinically shown to cause the release of endorphins and enkephalins. And the reason we know that is we took patients who had maybe neck pain or low back pain. We subjected them to acupuncture, specific techniques, and then they went to an MRI machine, which we do something called functional MRI. We inject a special form of glucose that lights up in the brain. And when we imaged the brains of these patients that had acupuncture, we could actually see they had an MRI before and an MRI after, so the areas of pain would light up in the prefrontal cortex. And then when we did the acupuncture on these patients, the signal went away. So we know there has been clinical trials that have looked at that, and the more that we get in pain management, the more we're going to find out about that. Only contraindication to acupuncture is active pregnancy, okay? Because we actually have been studies where we use acupuncture for fertility, so the thoughts are perhaps it can stimulate hormone release that could lead to premature delivery of a baby. And so that's really the only contraindications. If they use acupuncture that they kind of hook up to the electrodes, we sometimes try to avoid that in patients with implanted defibrillators, so they don't get shocked every time they turn on the acupuncture machine. But otherwise, it has been shown to be effective. So if you do have, more and more insurance companies are now starting to pay for this because of the clinical-based studies, and we're pushing that. As pain management practitioners and multidisciplinary pain management practitioners, we really do like acupuncture. Okay? Nutrition, something I'm terrible at, we're all terrible at. We did talk about a little bit, but it is important. What's important is, and certainly we did discuss the gluten diets. Gluten, our major immune organ in our body is actually our gut. And I think Dr. Kush had said that. So if we can use agents that are low in starch, low in wheat, we can lead to increased anti-inflammation. We know our leafy greens, our carotenoids, and our fruits and berries, especially raspberries and blueberries, have shown to have anti-inflammatory properties. The others are the fish oils, omega-3 fatty acids, are also have been looked at not only in cardiac disease, but in pain management. And so every one of our patients meets with certified nutritionists. We go over what they eat. We go over a slow modification of that, because let's face it, it's hard to change some things. You know, some people have to have a Twinkie once in a while, and that's okay. But if we can use our diets that are more rich in vegetables, berries. Now there are certain fruits that are not great for for inflammation. But we know that the berries, nuts, and some of the essential oils that we get from fish and some meats have been helpful. So talking to a nutritionist is not a bad thing to do if you do suffer from the pain. Yoga is fantastic. Why? Well, it does two things. It causes a relaxing mood, so we kind of calm down, and it also allows us to stretch. For the positions that it does help us stretch. It helps us kind of allow for extension-based exercises, which we see in yoga. I've tried Pilates. I think I fell on the floor and couldn't get back up when I tried it. I'm not very good at yoga myself. That's okay. Some of the Tai Chi stuff is very effective, but if you can do yoga, to the degree you can do it, do it. I think it's a very helpful thing, and it has been shown to be helpful. And again, we're not talking about the progression of our disease, but we are talking about pain management. We are talking about our posture, and it is very helpful. Then mindfulness and meditation. This is something that has been coming up in the literature more and more these days, and it's really trying to get that time out, trying to focus on everything, not to focus on our pain, our daily routines, but to take that small amount of time during your day and focus, and especially if you go to somebody that can teach you well in these techniques, it can be very, very effective. And again, our learning to self-soothe, learning to take control of this disease that is taking control of us, we're much stronger than that. So that's why we do advocate meditation and mindfulness. And then spirituality. Spirituality is very important. All of our patients do, if they would like, and some people are not spiritual, but if they are, we really do advocate that they maintain that. It maintains a routine, it empowers people, and that therefore decreases pain. So with that, C.S. Lewis is one I like. You don't have a soul, you are a soul, and you have a body. And some of us have a body right now that might not feel so good, but that's not us. This disease isn't us. It doesn't define us. And that's why we want to set you free from that and do anything that we can to help out. So with that, I think I'm about done.